So I think we finished class the other day talking about headaches. So let's dive deeper into primary brain tumors. Primary brain tumors really are those that originate in the brain. Many times brain tumors are very slow growing. Often they can be benign tumors, but also cause significant problems because they increase the intracranial pressure and cause significant problems that way. But also they can be very highly aggressive tumors and very malignant, again causing some significant problems with the patient in terms of intracranial pressure issues. There are various different kinds of brain tumors. You can see that gliomas are the kind that tend to develop along the curved areas of the brain, so we have an increased risk most times for those patients to be in the frontal lobes, which are more susceptible to those type of gliomas. But frequently they're found, younger people, 20 to 50, and they a few grades, grade 1 and grade 2 are slow growing, but also grade 3 tumors can be anaplastic gliomas and cause some significant rapid growth and poor control and differentiation of those cells. So they can impact the surrounding vessels of the brain pretty significantly and causing many times these patients present with bleeding. And then meningiomas are the most common form, and they occur kind of middle age, 40 to 70. And oligodendrogliomas are those slow-growing tumors that really don't spread to any of the surrounding tissue, but they impact the myelin sheaths that originate from the oligodendrites as well. And then acoustic neuromas impact the cranial nerve, the acoustic nerve, that can be slow growing and typically doesn't invade any other tissues, but because of its position, it can have some significant compression on other nerves, notably 5, 7, 9, and 10. And there can be some significant complications because of that. Very frequently, these patients end up having some problems really kind of depend upon, as I said previously, the location, based on the location and the degree that it causes intracranial pressure issues. Certainly the management of those patients involve a wide variety of treatments. Chemotherapy, very frequent, and chemotherapy and radiation is very frequently used. However, these options more so are to many times decrease the size of the tumor so that the patient can potentially have a craniotomy with removal. But often these patients will have biopsies prior to having the tumors removed so that they can be specific treatments identified for those patients at that point. Certainly some complications that we've already talked a little bit about in terms of bleeding, but also can cause significant cerebral edema, vasogenic edema really around the site of the tumor. Can cause cytokine and interleukin release in some of those tissues that can be pretty toxic to the surrounding tissues. High risk of people having seizures with brain tumors. I had a friend once who didn't know she had a brain tumor, but the only presenting symptom she had was when she had a seizure. She was a home health nurse and had a seizure in a patient's kitchen and found to have a significant brain tumor that was excised and has subsequently recurred multiple times. Also, these patients can have venous thromboembolisms, not only from the peripheral perspective, but also in the basilar venous drainage system of the brain can cause some significant hemorrhage, significant embolisms that occur in those areas. And as we've already talked about, the ICP being elevated as well. So frequently these patients are going to have steroids added to decrease the cerebral edema, but also importantly to watch their sodiums and their glucose, because people end up having significant swings in their intracranial pressure because of their sodium changes. Obviously, we need to watch their eyes and nose very strictly with these patients, very comprehensively, so as we prevent any kind of dehydration. Patients who get dehydrated can have a decrease in the volume and cause a significant overall outcomes. The head of the bed really needs to be elevated and the head of the bed not only needs to be elevated, but the patient needs to stay midline. Their head needs to stay midline so as we don't change any drainage processes to the venous system there. And certainly patients who have these drainage system potential problems, having any kind of big central line placed in their neck would be contraindicated because of that potentially inhibition of drainage. Certainly stool softeners are going to be important, anti-epileptics, so that people, if they do develop seizures, or really to prevent them from developing seizures, but they just have to be aggressively treated. And then any kind of ways that we can prevent venous thromboembolisms from developing. So let's switch gears a little bit and talk about patients with epilepsy and what that really means. Epilepsy really is this sudden change in their overall electrical stimulus and activity that occurs in the brain, and people can have some significant neurologic decline, but also systemic and respiratory decline with seizures. So pathophys, no real conclusive explanation. There's some genetic predisposition to seizures sometimes, but also we can have the gamma aminobutyric acid having some interactions with those patients as well. There's some classifications of seizures, absent seizures. Usually you see the onset years and you see what kind of the differences between in terms of the physical signs that they may show. Some brief loss of consciousness with absent seizures lasting just a few minutes, all the way to myoclonic seizures that really could occur in any group. There's no real loss of consciousness. However, people can have this muscle spasming type issues, and then also tonic-clonic seizures, which is the full-on, tonicity of their phases that are intermixed with clonics, and the rhythmic jerking is the thing that we typically think of whenever we think of people having seizures. Really, when people can develop epilepsy and have seizures that are unprovoked by any kind of immediate cause, if those occur within a 24-hour period, then patients are stated to have epilepsy. And some of the risk factors, we've already talked about some tumors in development, but certainly metabolic disorders. We think about acidemic issues or or alkalemic problems. Actually, people can have seizures from. People can have seizures from withdrawing medications, electrical disturbances, certainly heart disease from a low perfusion state. People can have high fevers that end up having seizures. Strokes, again, because of the irritability of the tissue in the surrounding areas of the stroke, either being hemorrhagic or ischemic, can certainly increase the risk of people having seizures, and then certainly substance abuse may be an issue as well. People can have that rhythmic jerkiness that we talked about already, or they can just have that episodes of kind of this appearance of daydreaming, kind of just staring off into space. Sometimes can lead to can be a seizure itself. You have to think about some imaging and some laboratory workup. Certainly think about, as we've talked in class multiple times, some laboratory data that may be beneficial in terms of deciding if we have any kind of metabolic disturbances that should be fixed or treated prior to any other aggressive treatments to see if those seizures will go away. EEGs are the best way that we can evaluate the brain, and they can show there are multiple different leads that are placed on the brain, and actually what that's going to do is show us if there's a targeted area that the seizure is originating from. We think about how to manage seizures. If people have these tonic-clonic seizures, adding some kind of benzodiazepine to break the seizure, and then some anti-epileptics with phenytoin or phosphonatoin, drugs like that will potentially decrease the excitability of the of those certain areas. Have to think about if patients are on other medications. If we have CNS drugs added, then they could be presenting themselves as inducers or inhibitors of some other medications, if you'll remember back to pharmacology. So just be mindful that we have to investigate some areas of concern with some of those medications. Typically, though, we're going to end up giving Ativan. 2 milligrams IV is kind of the standard that you're going to see administered for patients with seizures. There's some other treatment algorithms and vagal nerve stimulators that are thought to decrease the overexcitability of certain areas, that if it's really coming from deep inside the brain. Sometimes there's partial corpus callosum, corpus callosostomy that potentially would decrease the likelihood of spreading the seizure from one hemisphere to the next in terms of massive tonic-clonic type responses. Certainly some drug therapies we've already evaluated and thought about in terms of some of these interactions with warfarin and phenytoin you have to be aware of. And dilantin in itself causes some pretty significant complications and profound drug interactions and problems. People that have seizures greater than 5 minutes we really are in a medical emergency, and we have to think about how to break this seizure, to suppress their seizures completely so that we're not just basically burning up the brain. People that have respiratory failure and brain damage and certainly death can lead from ongoing seizures. So rapidly identifying a seizure and reversing or preventing worsening or preventing ongoing seizures is very important. So you have to think about respiratory failure with these patients. The old adage is stick a tongue blade in people's mouth so they don't bite their tongue or swallow their tongue. All that's garbage. You have to really worry about people not maintaining their airway in terms of head positioning, in terms of vomiting, in terms of excessive frothy secretions. So just be very mindful of how people who develop respiratory failure, how you would manage those individuals. And you always have to think about airway, breathing, circulation, the ABCs that we talk about all the time, but certainly airway. Airway is very important in maintaining an open a patent airway so that people can breathe if they are having seizures and have diaphragmatic activity. But if people progress to the point that they have to be bagged or placed on a breathing machine, it's not uncommon at all sometimes with those patients. So really, you think about some seizure precautions. What really is the first action? You want to put on some oxygen on the patient to help support what's there. Suction the airway. You got to keep the airway patent, keep it open. You got to think about how are we going to reverse this in terms of IV access, but also don't forget about using interosseous access if IV access may be challenging to get. And then we really increase the chances of people having a good outcome if we can treat their seizures, but also maintain adequate airway. People with seizures frequently describe this aura or green around lights or some kind of weird aura or sensation prior to having a seizure. It's interesting. Obviously, compliance with any kind of anti-epileptic medication is very important. And interestingly, people who have a single seizure actually are restricted from driving their car from any kind of driving really for 6 months. And if people have more than one seizure, their driver's license really is in question. And even if they've lasted the 6 months without a seizure, if they have more than one seizure, then they may have limitations to their driver's license with those ongoing seizures. Certainly a single seizure will prevent someone from driving for 6 months, and then multiple seizures within that 6 month period may actually end up having revoking of their license. So let's switch gears a little bit and talk about meningitis. And people with meningitis people get meningitis usually who live in very close proximities. You think about dormitories or colleges or the barracks in the army or some military service. There's increased risk of potential development of spreading meningitis, and it's really the inflammation of the meninges And they can come from various different areas. We can have bacterial, viral, fungal, and aseptic meningitis where there's no organism identified, but there's just inflammation of the meninges occurring. And people typically get the fever, headache, and they really have this altered mental status. People very frequently complain of photophobia, and then this nausea and vomiting is pretty significant. We talked about the nuchal rigidity and the epistamosis that occurs with people having meningitis, the severe hyperextension and arching of their back that occurs because of the ongoing meningitis. And then certainly there are other, causes of meningitis that you can think about in terms of pericarditis or myocarditis can lead to meningitis as well. And as you can see, there's an extended period of treatment, antibiotic therapy for those patients if it's bacterial, and then examining with their CSF via a lumbar puncture is going to be the best way to identify organisms. Certainly you worry about increased intracranial pressure with these individuals, and then people can end up having significant comorbidities with meningitis itself, like seizures. They can develop SIADH or diabetes insipidus that we'll get to in the next few weeks. That can be quite debilitating and limiting for these patients. And then Parkinson's disease, you can see the epidemiology and the pathophysiology. Typically is this neurodegenerative disorder that occurs in various parts of the brain. That's because this dopamine producing cell there's a reduction in the dopamine producing brain cells that could lead to significant rigidity issues. You can take some time to look at this video, but you can see people with Parkinson's have tremors. Very frequently they have these issues with their face in terms of mask-like appearances. Very frequently they have this stooped feature, stooped posture. People have these flexed arms and elbows that really, whenever they're walking, they're straight. They're not moving kind of the normal gait that you would see with patients. Clinical manifestations, you can see there various different symptoms, including tremors, muscle rigidity, bradykinesia, akinesia. People can have some progressive stages and some various medications being Cinemet that we could use. Sometimes some anticholinergics are used for the patients. And very frequently, sometimes people end up having electrical stimulating devices placed to try to prevent the worsening of the disease, or treat really the symptoms. We're not going to treat the disease, is not going to go away, but trying to treat the symptoms. Complications, you end up having people to develop pneumonia because of swallowing and choking issues. So really thinking about teaching the family about small bite-sized foods and portions really is an important way that we can limit potential pneumonia that occurs from these patients. And then certainly fall risk and kind of teaching the patient's family about what to do at home if there is an issue. And then Alzheimer's, we've already talked about multiple times, but Alzheimer's, is affecting memory and thinking and behavior. Just be cognizant that, people who develop Alzheimer's kind of earlier on in life can live for a pretty extensive period. They're having problems in terms of dementia development, but their bodies still could be healthy and they could, be living for an extended period of time. Again, diagnostics, we need to rule out any other causes with CTs or any kind of MRIs or PET scans to evaluate any other significant potential causes of why people are presenting that way. And then biomarkers we can look at. I'm not really going to get into this other than just know that there's not a cure, and there's been some medications that have been introduced that have been reasonably successful. I'm saying reasonably successful. There have been some medications that have treated the symptoms with some hope and some positive issues. And these are some medications here. So look those medications up and think about in terms of what are their problems that they potentially could cause for patients. And then Huntington's disease, This is this disease that shows up later in life, very frequently after people have already had children. They deteriorate from the physical and mental abilities really kind of in the prime part of their life. It affects a significant number of people. They have personality changes, mood changes, depression, and then they have unsteady gait and involuntary movements that occur. People have this progressive worsening of their neurologic symptoms, ultimately where they develop some kind of respiratory failure and then aspiration, and very frequently die from those things. So please let me know if you have any questions or comments, and I look forward to seeing you in class.